Tonsillectomy. The learning objectives of this video are to explain the anatomy and pathophysiology, describe key considerations for the preoperative anesthetic evaluation and intraoperative anesthetic management plan, review common operative approaches, and discuss postoperative considerations involved in tonsillectomy. Tonsillectomy with or without adenoidectomy is one of the most common medical procedures in children. Adenoidectomy is beyond the scope of this video, but the preoperative evaluation and postoperative management are very similar. While the number of tonsillectomies performed in the U.S. has steadily decreased since the 1970s, over 250,000 tonsillectomy procedures are performed in the U.S. annually. Hospital revisits occur in 5 to 15% of patients, most commonly due to post-tonsillectomy hemorrhage, fever, nausea and vomiting, dehydration, and pain. Anatomy and pathophysiology. Tonsillectomy involves the surgical removal of the palatine tonsils, which are lymphatic tissue located in Waldeyer's ring in the lateral pharyngeal wall of the oropharynx. Other structures contained in this ring include the adenoid tonsil, tubal tonsils, and lingual tonsil, but those are not typically removed in a standard tonsillectomy. The palatine tonsils are separated from surrounding musculature by a fibrous capsule and are located in the tonsillar fossa, which is defined by the palatoglossal arch anteriorly, the palatopharyngeal arch posteriorly, and the superior pharyngeal constrictor muscle laterally. Blood supply to the palatine tonsils is provided by branches of the external carotid artery, the tonsillar branch of the facial artery, the ascending palatine branch of the facial artery, the ascending pharyngeal artery, the tonsillar branch of the dorsal lingual artery, and the lesser palatine artery from the maxillary artery. Innervation is from the sphenopalatine ganglion via the lesser palatine nerve and the glossopharyngeal nerve. The glossopharyngeal nerve lies immediately deep to the muscles that define the tonsillar fossa, making it susceptible to injury during the procedure. The most recent clinical practice guidelines regarding tonsillectomy in children are published by the American Academy of Otolaryngology Head and Neck Surgery Foundation. The two most common clinical indications for tonsillectomy and/or adenoidectomy are airway obstruction resulting in obstructive sleep-disordered breathing and recurrent tonsillitis due to infection. History and physical examination can be used to diagnose sleep-disordered breathing, with obstructive sleep apnea on the severe end of the spectrum. Further evaluation with polysomnography can be beneficial in children with signs of sleep-disordered breathing without visible tonsillar hypertrophy. A polysomnogram can also be considered in children less than 2 years of age or PE patients with obesity, trisomy 21, craniofacial abnormalities, neuromuscular disorders, sickle cell disease, and mucopolysaccharidosis, even if adenotonsillar hypertrophy is present. The severity of obstructive sleep apnea is graded based on the number of hypopneas and apneas that the child has per hour, also known as the apnea-hypopnea index, or an AHI. A child with an AHI of 1 to 5 events per hour may have mild sleep apnea. A child with an AHI of 6 to 10 events per hour may have moderate sleep apnea, and a child with an AHI of greater than 10 events per hour may have severe sleep apnea. This diagnosis is common in children and is important to recognize as it can result in a range of cardiovascular and cognitive comorbidities if left untreated. Tonsillar and adenoid hypertrophy are the most common cause of sleep-disordered breathing. Tonsil hypertrophy is often graded on a scale from 1 to 4, but tonsillar size does not always correlate with the severity of symptoms. The decision to treat with tonsillectomy with or without adenoidectomy is made on a case-by-case basis, taking into consideration the age of the child, severity of symptoms, polysomnographic abnormalities, and comorbid conditions. Recent research suggests a nuanced approach to the use of tonsillectomy as the first-line treatment for children with obstructive sleep apnea and sleep-disordered breathing, emphasizing its potential benefits beyond cognitive aspects, while also highlighting the role of watchful waiting in guiding treatment decisions. When considering adenotonsillectomy as a treatment option for recurrent infection, the Paradise criteria should be used. These criteria define the minimum frequency of sore throat episodes a child needs to qualify for tonsillectomy, the clinical features that must be present with each sore throat episode, treatment options that should be administered prior to considering a tonsillectomy, as well as how each sore throat episode should be documented. The minimum frequency of sore throat episodes a child needs to qualify for tonsillectomy is as follows: at least 7 episodes of sore throat in the previous year, or at least 5 episodes in each of the previous 2 years, or at least 3 episodes in each of the previous 3 years. In order to count towards the minimum frequency, each sore throat episode must be accompanied by one of the following clinical features: a temperature greater than 101 degrees Fahrenheit, cervical adenopathy, or tender lymph nodes or lymph node size greater than 2 centimeters, tonsillar exudate, or a culture positive for group A beta hemolytic streptococcus. For these episodes, antibiotics should have been administered in the conventional dosage for proven or suspected streptococcal episodes. Finally, each episode of sore throat infection and its qualifying features need to be thoroughly documented in the patient's medical record. If episodes are not appropriately documented, the physician needs to observe 2 episodes of throat infection with patterns of frequency and clinical features as outlined above. Preoperative evaluation. In preparation for tonsillectomy and/or adenoidectomy, evaluation of a patient should begin with a standard history and physical examination, with special attention paid towards assessing for potential contraindications and/or conditions associated with increased risk of perioperative complications. Preoperative evaluation should include investigation of clinical signs of anemia or bleeding disorders. There are validated questionnaires that may be used for preoperative screening, including assessing personal or family history of unusual bleeding or bruising. A laboratory evaluation and possibly referral to a pediatric hematologist may be warranted. If surgery is deemed appropriate for children with anemia, consultation with the hematology service is important for preoperative and postoperative management. Velopharyngeal dysfunction is also an important consideration prior to surgery. Velopharyngeal dysfunction is characterized by abnormal function of the velopharyngeal valve and includes overt or submucous cleft palate, neurological or neuromuscular abnormalities causing impaired palatal function, or an unusually spacious pharynx. These conditions can be identified by careful inspection of the palate and evaluation for symptoms of hypernasality. If velopharyngeal dysfunction is identified preoperatively, a partial or superior adenoidectomy can be considered, but parents should be informed of the risk of worsening velopharyngeal dysfunction. Anesthetic management. The anesthesiologist is posed with a unique set of challenges during adenotonsillectomy for both operative and patient considerations. Patients presenting for adenotonsillectomy may have known or suspected obstructive sleep apnea as a result of upper airway obstruction, which increases the risk of hypoxemia during the pre-induction phase after receiving sedative or hypnotic medications. This risk persists during induction of general anesthesia, which is often achieved via inhalation induction with volatile anesthetic agents such as sevoflurane. To treat acute airway obstruction following induction, the anesthesiologist may perform jaw thrust maneuvers, attempt repositioning of the head, apply continuous positive airway pressure or CPAP, or insert a nasal oral airway adjunct. After induction of general anesthesia, intravenous access is obtained. For patients with severe obstructive sleep apnea or other high-risk comorbidities, a pre-induction IV will provide an extra measure of safety should ventilation prove challenging during induction. A shoulder roll may be helpful in visualizing the airway for intubation as well as the procedure itself. Many anesthesiologists favor use of a cuffed endotracheal tube, which has the advantage of blocking pooled secretions and blood from entering the trachea. Others may prefer use of a laryngeal mask airway, or LMA, which has been suggested to facilitate more rapid time to extubation at the conclusion of the procedure. Both an endotracheal tube and LMA are at risk of kinking during the procedure after placement of the mouth gag. Thus, the anesthesiologist must pay careful attention to the positioning of the airway, as well as peak pressures on the ventilator during the surgery. During the procedure, the anesthesiologist must carefully titrate analgesic medications to facilitate a smooth emergence and postoperative course. Analgesia is typically multimodal in nature, incorporating acetaminophen, dexamethasone, and NSAIDs when surgically not contraindicated. Dexamethasone has the added benefit of decreasing postoperative airway swelling in addition to providing antiemetic properties. Judicious doses of opioids are often used, though there are ongoing investigations into opiate-free anesthetics for adenotonsillectomy. The anesthesiologist must carefully dose opioid medications in patients with obstructive physiology due to increased risk of respiratory depression and postoperative apnea while providing adequate analgesia to avoid coughing and agitation following emergence, as this can lead to bleeding. Operative approach. There are multiple methods for removing tonsils. There are hot procedures using cautery, as well as cold procedures using sharp dissection. During hot procedures, using a low FiO2 can help minimize the risk of airway fire by decreasing the amount of oxygen available for combustion. Additionally, the procedure can be extracapsular or intracapsular. Extracapsular tonsillectomy involves removal of the entire tonsil with dissection along the tonsil capsule to ensure complete removal. Intracapsular surgery, also referred to as tonsillotomy, involves removal of the obstructive component of the tonsil, with the rim of the tonsil left in situ. The benefits of tonsillotomy include less postoperative pain, intraoperative blood loss, and surgical time. But there is a risk of tonsil regrowth with an estimated 1 to 2% of patients requiring a revision tonsillectomy. There is no single best operative method. Which technique is used depends on the surgeon's experience and comfort level. The hot extracapsular technique using monopolar cautery is the most used technique in the United States. In this technique, after the posterior and lateral walls of the palate are carefully inspected and palpated to detect abnormally positioned vessels, the superior pole of the tonsil is grasped with the Alice clamp. The tonsil is retracted medially to determine the lateral extent of the tonsil and to aid with dissection. An incision is made in the superior pole using electrocautery, and the entire palatine tonsil is removed from superior to inferior pole. It is important to dissect along the tonsil capsule and avoid injury to the adjacent musculature. Preserving as much of the anterior and posterior tonsillar pillars as possible is also important for postoperative phylopharyngeal function. Hemostasis during the procedure is maintained via packing, suction, and cautery. Postoperative care. The most common issues following tonsillectomy depend on the indication for the procedure. Postoperative respiratory complications have an incidence of 9% and range in severity from mild desaturation to life-threatening airway obstruction. Children at increased risk of respiratory compromise include patients with obstructive sleep apnea, obesity, age of less than 3 years, craniofacial abnormalities, sickle cell disease, Down syndrome, neurologic disorders such as cerebral palsy, mucopolysaccharidosis, history of asthma, and recent upper airway infection. In patients with obstructive sleep-disordered breathing, worsening airway obstruction due to postoperative swelling in the pharynx is possible. Therefore, close postoperative airway monitoring is essential. Monitoring may consist of continuous pulse oximetry and frequent nursing evaluations. In patients with signs or symptoms of airway obstruction, oxygen therapy, repositioning, intravenous steroids, and racemic epinephrine can all be considered. In patients with more severe obstruction, non-invasive positive pressure, CPAP, or BiPAP therapy can be considered. Non-invasive pressure support does not increase the risk of bleeding following tonsillectomy. Another significant potential respiratory complication is post-obstructive pulmonary edema. This rare but potentially severe complication may be related to one of two proposed pathophysiologic processes. The first is from acute airway obstruction, such as from airway swelling after surgery, or laryngospasm during emergence from general anesthesia. When a patient tries to breathe against an obstructed airway, they generate a significantly increased negative intrathoracic pressure, which increases venous return to the right side of the heart. The increased venous return leads to increased blood flow through the pulmonary vasculature and acute increase in hydrostatic pressure, thereby increasing the hydrostatic transpulmonary gradient and leading to fluid shifts into the pulmonary interstitium and alveoli. This desaturation typically presents right after the period of acute airway obstruction or occlusion with spontaneous patient respiratory effort. The second theoretical mechanism by which post-tonsillectomy patients may develop post-obstructive pulmonary edema is due to acute relief of upper airway obstruction. Patients with severe obstructive sleep apnea may have chronic increase in end expiratory lung volume, pressure, and interstitial membrane permeability due to chronic airway obstruction. With relief of the obstruction, the lung volumes and pressures acutely return to normal, but membrane permeability does not, thereby resulting in fluid transudation due to pressure changes and subsequent pulmonary edema. This may develop in the first hours after tonsillectomy surgery, thus warranting post-operative monitoring for patients with severe obstructive sleep apnea. The therapy for post-obstructive pulmonary edema is to ensure airway patency, provide respiratory support to achieve adequate oxygenation and ventilation, and institute supportive therapies such as minimizing fluid intake and initiating diuresis. Pain is common following surgery, including both pain from the surgical site as well as otalgia from referred pain from the pharynx. Pain-relieving medication should be given on a schedule, with first-line therapy being acetaminophen, often also with a non-steroidal anti-inflammatory drug, such as ibuprofen. Studies have shown that these medications are equally effective when compared with opioid medications. Morphine and oxycodone are reserved for pain not relieved by acetaminophen or NSAIDs. Codeine should absolutely not be administered to post-tonsillectomy patients, as there are reported severe or life-threatening complications in children who are ultra-rapid metabolizers of codeine who might be first exposed to this medication after tonsillectomy. Pain typically lasts 7 to 14 days following the procedure and may lead the patient to decrease their intake of liquids. But mandating oral fluid intake before discharge does not decrease incidence of dehydration. Many surgeons recommend a soft diet for 1 to 2 weeks following surgery for patient comfort and to minimize the risk of injury to the tonsillar fossa. Inadequate nausea control can also lead to poor oral intake and dehydration. Administering a single dose of glucocorticoids such as dexamethasone intraoperatively can help reduce postoperative nausea, vomiting, and pain. But postoperative treatment with oral glucocorticoids is not routinely recommended. Bleeding is both one of the most common and most feared complications following tonsillectomy. Bleeding which occurs immediately postoperatively within the first 24 hours is referred to as a primary bleed. Secondary bleeds are much more common and typically occur between 5 to 10 days after surgery when the eschar begins to fall off. Postoperative bleeding is considered an emergency as it can lead to significant blood loss, airway obstruction, aspiration, and very rarely, death. One study of over 550,000 pediatric patients showed 1.58% of children had unplanned revisits due to bleeding. If a patient starts bleeding while admitted to the hospital, the surgeon should be alerted immediately. The patient should be instructed to lean forward to avoid aspiration and/or the swallowing of blood. In the case of brisk bleeding, Gauze or a sponge on a long clamp can be used to temporarily tamponade the bleeding source while the patient is being intubated or taken into the operating room. Patients with significant bleeding may require volume resuscitation. Emergent cautery in the operating room may be necessary to control bleeding. Thank you for watching this video on tonsillectomy.